Painful menstruation, or dysmenorrhea, affects many women, causing discomfort that ranges from mild to debilitating. The primary cause is the release of prostaglandins, hormone-like compounds that trigger uterine contractions to expel the uterine lining during menstruation. Higher prostaglandin levels intensify these contractions, leading to cramping, lower abdominal pain, and sometimes nausea or headaches. This is known as primary dysmenorrhea, typically starting with menstruation and lasting 1 to 3 days. Secondary dysmenorrhea, however, stems from underlying medical conditions. Endometriosis, where tissue similar to the uterine lining grows outside the uterus, causes inflammation and severe pain. Uterine fibroids, non-cancerous growths, can press on surrounding tissues, exacerbating discomfort. Adenomyosis, where the uterine lining invades the uterine muscle, leads to intense cramping.
I was diagnosed with endometriosis 3 months ago, and it was like everything I've been saying had been validated. I'd been telling everyone I was in this pain, and for years I didn't feel believed.
More than 1,300 women from London have shared their experiences of endometriosis with the BBC.
And it's not as simple as just doing an operation and that makes you better and there you are, off you go, or have some medication and that's you fixed. So it's just about recognising the impact that this can have on, if you've got a friend or a relative who's got endometriosis, just recognising how very real that is.
Dysmenorrhea is a complex condition, and understanding its causes requires delving into both physiological and pathological factors. Primary dysmenorrhea is largely driven by the body's natural menstrual process. Prostaglandins, produced in the uterine lining, peak just before and during the first days of menstruation, causing the uterus to contract. These contractions reduce blood flow to the uterine muscle, leading to ischemia and pain. The severity varies among individuals, influenced by prostaglandin levels, which can be affected by genetics, lifestyle, or hormonal fluctuations. Women with higher prostaglandin production often experience more intense pain, sometimes accompanied by systemic symptoms like fatigue, diarrhea, or vomiting. The pain typically subsides as prostaglandin levels drop after the first few days of the menstrual cycle. Secondary dysmenorrhea, in contrast, signals an underlying issue that requires medical attention. Endometriosis is one of the most common culprits, affecting approximately 10% of women of reproductive age. In this condition, endometrial-like tissue grows on the ovaries, fallopian tubes, or other pelvic structures, responding to hormonal changes and causing inflammation, scarring, and adhesions. This leads to severe, sometimes debilitating pain that may persist beyond menstruation. Women with endometriosis often report pain during intercourse, bowel movements, or ovulation, alongside heavy menstrual bleeding. Diagnosis can be challenging, often requiring laparoscopy to confirm, as symptoms overlap with other conditions. Uterine fibroids, benign tumors in the uterine wall, are another frequent cause of secondary dysmenorrhea. Affecting up to 70% of women by age 50, fibroids vary in size and location, influencing the severity of symptoms. Submucosal fibroids, which grow into the uterine cavity, are particularly likely to cause painful, heavy periods. The pressure from fibroids on surrounding tissues or their interference with uterine contractions can amplify menstrual pain. While some women with fibroids are asymptomatic, others experience significant discomfort, often requiring imaging like ultrasounds or MRIs for diagnosis. Adenomyosis, less common but equally impactful, occurs when the endometrial tissue grows into the uterine muscle. This leads to an enlarged, tender uterus and intense menstrual pain, often described as deep and aching. Unlike endometriosis, adenomyosis is confined to the uterus, but the pain can be severe, particularly during menstruation, and may worsen with age or after childbirth. Diagnosis typically involves ultrasound or MRI, though a definitive diagnosis may require histological examination post-hysterectomy. Pelvic inflammatory disease, PID, often a complication of sexually transmitted infections like chlamydia or gonorrhea, can also cause painful periods. PID leads to inflammation of the reproductive organs, resulting in chronic pelvic pain, irregular bleeding, and discomfort during menstruation. If untreated, PID can cause long-term complications like infertility or ectopic pregnancy, making early diagnosis through clinical evaluation and testing critical. Cervical stenosis, a less common cause, occurs when the cervical opening is too narrow to allow normal menstrual flow. This obstruction causes a buildup of menstrual blood, increasing intrauterine pressure and pain. Congenital factors or scarring from procedures like cervical surgery can contribute to this condition. Treatment may involve cervical dilation to restore normal flow. Beyond these conditions, other factors can exacerbate dysmenorrhea. Hormonal imbalances, such as those seen in polycystic ovary syndrome, PCOS, can lead to irregular or heavy periods, intensifying pain. Stress and psychological factors can amplify pain perception, as the brain's pain pathways are influenced by emotional states. Poor diet, particularly high intake of inflammatory foods like processed sugars or trans fats, may increase prostaglandin production, worsening symptoms. Lack of physical activity can also contribute, as exercise promotes blood flow and reduces muscle tension, potentially alleviating cramps. Lifestyle factors play a significant role in managing dysmenorrhea. Regular exercise, a balanced diet rich in anti-inflammatory foods like omega-3 fatty acids, and stress management techniques such as yoga or meditation can reduce the severity of primary dysmenorrhea. Heat therapy, applied to the lower abdomen, is a well-documented non-pharmacological remedy that relaxes uterine muscles and improves blood flow. Over-the-counter medications like ibuprofen or naproxen, which inhibit prostaglandin production, are effective for many women. For severe cases, hormonal treatments like oral contraceptives or intrauterine devices, IUDs, can regulate or suppress menstruation, reducing pain. In conclusion, painful menstruation arises from a complex interplay of physiological, pathological, and lifestyle factors. Primary dysmenorrhea is driven by prostaglandin-induced contractions, while secondary dysmenorrhea reflects conditions like endometriosis, fibroids, or PID. Accurate diagnosis through clinical evaluation and imaging is essential for effective treatment. Women can manage symptoms through lifestyle changes, medications, or targeted therapies, but persistent pain warrants professional attention to address underlying causes and improve quality of life. Hey, thanks for sticking with me through this deep dive into painful menstruation. If you found this information helpful, please give it a like and share it with others who might benefit. Don't forget to subscribe for more health insights and tips to empower your wellness journey. Drop a comment if you have questions or topics you'd like me to cover next. Stay informed, stay healthy, and I'll see you in the next one.